All right, everyone. It's now noon o'clock. This is Clark Barano with the Medical Society of Virginia. We want to thank everyone for attending today's webinar. We currently have 177 attendees signed in, along with about 300 signed up. So everyone attending, with the exception of myself and VDH, are on mute. If you please would like to submit any additional questions, please submit questions in the questions section of GoToMeeting. We have questions that were submitted through the registration process, and we're going to get to those at the end of Dr. Peake's presentation. Also, I wanted to let everyone know that this webinar is being recorded. We will add it to the Medical Society of Virginia's website at msv.org/COVID-19 when this is all concluded. Now I'd like to introduce Dr. Lilian Peake. Dr. Peake is Virginia State Epidemiologist working on with the Virginia Department of Health. Prior to that role, she worked as the Director of Public Health for the South Carolina Department of Health and Environmental Control. Dr. Peake has been working with the Governor, VDH, healthcare stakeholders, and many others to manage the Commonwealth's response to COVID-19. We sincerely appreciate her time today, and we're going to turn it over to her.
Good morning. Thank you for taking time to join us today. SARS-CoV-2, the virus that causes COVID-19, was identified through a Chinese surveillance system established following the 2002 SARS outbreak to detect emerging respiratory pathogens. A patient specimen tested positive for pan-beta coronavirus using a PCR test, but was negative for known human beta coronaviruses. Whole genome sequences of the virus were acquired. Bioinformatic analyses showed a 96% match with a bat SARS-like coronavirus strain. Based on this analysis, bats appear to be the reservoir of SARS-CoV-2, but the intermediate host animal has not yet been identified. Subsequent studies indicate the virus emerged sometime in November or December. The World Health Organization released a report about the COVID-19 epidemic based on a joint mission to Wuhan, the city where the epidemic began. It was attended by 25 experts from several countries, including the United States. The group received briefings, reviewed data, published literature, and they conducted field visits. The report includes information about China's outbreak as of February 20th. At that point, China had confirmed about 56,000 cases through laboratory testing. Among the confirmed cases, most had fever and/or dry cough. 77% of the cases were from Hubei, the province that includes the city of Wuhan. The median age was 51, with a range from 2 days old to 100 years old. Less than 3% of the cases were children. About half were male. Most people had mild illness. About 20% had severe or critical disease. Asymptomatic disease was reported, but appears to have been relatively rare. The World Health Organization stated that it did not appear to be a major driver of transmission in China. Before interventions were introduced, it's estimated that each infected person spread the virus to 2 to 3 other people. The median time from onset to clinical recovery for mild illness was approximately 2 weeks. Preliminary data showed that the time from onset to the development of severe disease, including hypoxia, was 1 week. Severe disease or death was associated with age over 60 and/or having comorbidities. Mortality increased with age and was highest among people over 60. The case fatality ratio among people without comorbid conditions was 1.4%. Mortality was higher among males than females. A very small proportion of children developed severe or critical disease. The overall case fatality ratio varied by location and intensity of transmission. It was higher in Wuhan than other areas in China and was higher in the earlier stages of the outbreak. In an investigation of 147 pregnant women, 8% had severe disease and 1% were critical. Instances of transmission within healthcare settings, prisons, and other closed settings was reported. Just over 2,000 lab-confirmed cases were among healthcare workers. The Joint Mission learned that among the healthcare worker infections, most were identified early in the outbreak in Wuhan when supplies and experience with the new disease was lower. Investigations among healthcare workers suggest that many may have been infected within the household rather than in a healthcare setting. China had a robust response and continues to have a response to this epidemic. They had a comprehensive public information campaign and created targeted education. They identified and isolated cases early and provided medical care. They identified and quarantined contacts of cases, tracked those cases, and also tracked the contacts. They expanded healthcare staffing and hospital bed capacity. They actually created some makeshift hospitals and built additional hospitals. They canceled mass gatherings. They closed early on the wet markets and wildlife markets when they were still trying to determine where the virus had come from. They banned travel in and out of Wuhan and surrounding jurisdictions, and they controlled transportation. Next slide, please. So the epidemic was reported to WHO on December 29th after Chinese public health authorities detected a cluster of pneumonia cases in Wuhan, which has a population of 11 million. Using the pneumonia of unknown etiology surveillance system to backtrack, the first confirmed case of the outbreak occurred on December 8th. Early cases are believed to have acquired infection from a zoonotic source, as many reported visiting or working in the Huanan wholesale seafood market. It sells a variety of animals. At some point early in the outbreak, some cases generated human-to-human transmission chains that seeded the subsequent community outbreaks. A week after detecting the first cluster, scientists in China had isolated the novel virus. China shared the genome with public health authorities globally. You can see from this epidemic curve, which shows the number of people who developed the illness each day and were reported to Chinese public health authorities, that the epidemic rapidly grew from January 10th through the 24th. On January 23rd, China banned travel in and out of Wuhan and the neighboring municipalities. This was primarily the Hubei province, which has a population of 58 million. The number of new cases plateaued between January 23rd and 27th and has been steadily declining since then, apart from a spike on February 1st. This is attributed to aggressive case and contact identification and extreme social distancing. As of yesterday, the WHO had reported about 110,000 confirmed cases, about 80,000 in China, and now nearly 30,000 outside of China. Cases have been confirmed in 104 countries and territories. Over 3,100 deaths from COVID-19 have been confirmed in China, and 686 have been confirmed outside of China. This map shows the distribution of cases around the world. There are hotspots in China, South Korea, Italy, and Iran. Each of those countries has about 7,000 cases. As of yesterday, 19 U.S. states had reported a total of 423 cases, including 19 deaths. Half of the cases are in California and Washington state. All but one death has occurred in Washington state. As of last night, we had identified 5 cases in Virginia. 4 are in the northern region and traveled internationally days before developing symptoms. 1 is in the northwest region, and potential exposures are still under investigation. Local health department staff are conducting contact tracing to identify people who had contact with the cases, so those people can undergo home quarantine and be monitored for symptoms. Outpatient settings play a key role in slowing the spread of COVID-19. Clinicians should obtain a travel history on patients with respiratory symptoms. Epidemiologic factors to help guide your decision on whether to test a patient for COVID-19 include any persons, including healthcare workers, who have had close contact with a laboratory-confirmed COVID-19 patient within 14 days of symptom onset, and patients who have traveled from an affected geographic area where the disease is spreading within 14 days of symptom onset. Influenza is still widespread in Virginia, so clinicians are strongly encouraged to test for other causes of respiratory illness, including influenza, to rule out other diagnoses. You should also consider COVID-19 in your differential diagnosis for medically fragile people who have the greatest risk for the poorest outcomes. This includes older adults and individuals with chronic medical conditions and or those who are immunocompromised with fever or respiratory illness. As the global situation continues to rapidly evolve, please refer to the CDC Travel Advisory's website, the links provided on this slide, for the most up-to-date advice. Currently, China, South Korea, Iran, and Italy are at level 3, the highest CDC level, in which CDC recommends that travelers avoid all non-essential travel. Travelers returning from those countries should self-quarantine for 14 days after returning. Travelers returning from countries with a level 2 travel alert, currently Japan, should limit interactions with others for 14 days after returning and monitor themselves for symptoms. As of yesterday, 418 travelers have been under public health monitoring in Virginia. 166 have completed monitoring, and 252 remain under monitoring. Virginia State Lab, DCLS, initiated COVID-19 testing here in Virginia on February 29th. Currently, they have a limited number of tests available. As of yesterday, they had supplies to test 300 to 400 people. They have ordered additional material from CDC. CDC shared yesterday that there is a backlog of reagents, so they will be distributing them equitably with a focus on areas with community transmission. In Virginia, where we don't have evidence yet of community transmission, it's important that we use criteria to identify people who were most at risk of being exposed. If we use our limited testing on people with no or low risk, it will impede our ability to identify cases quickly. BDH approval for testing at the state lab is required. Specimen collection information is available on the DCLS website. The estimated turnaround time for COVID-19 test results is 1 to 2 days. The assay that DCLS is using has greater than 95% sensitivity and specificity. Positive COVID-19 results from DCLS initially required confirmation at CDC. Private labs are now able to perform testing, and as of March 6th, there are some Virginia labs with this capability. Private labs are increasing their capacity to test every day and offer another avenue to test people who have no known exposures. Contact your lab provider to determine testing availability. The capacity in the private sector will continue to increase each week, and access will improve. Until more tests are available, BDH will be approving testing at the state lab based on the following clinical and epidemiologic criteria. First, a person who had close contact with a laboratory-confirmed COVID-19 patient within 14 days of onset and fever or signs and symptoms of a lower respiratory illness. Second, a person with a travel to a country with level 2 or 3 travel advisory or an area with confirmed ongoing community transmission, and that's within 14 days of onset, and has fever and signs or symptoms of a lower respiratory illness and tested negative for influenza on an initial workup. Third, it's a person who resides in a nursing home or a long-term care facility and who has fever or signs and symptoms of a lower respiratory illness, and who tested negative for influenza on initial workup and tested negative for a respiratory virus panel, and then has no alternative diagnosis. Any patient that a healthcare provider would like tested but does not meet criteria should try to access testing through a private lab. The current recommendations for caring for suspected or confirmed COVID-19 patients include placing the patient in an airborne infection isolation room. If an isolation room isn't available, place a face mask on the patient and isolate him or her in an examination room with the door closed. The patient should be given a face mask. Perform the standard workup for respiratory illnesses in addition to potential COVID-19 testing. In addition to room placement, staff should use the recommended personal protective equipment, PPE, and keep a log of all persons who care for or enter the room or care areas of the patients and immediately communicate with the local health department about any suspected cases. The minimum PPE requirements for healthcare providers in close contact with suspected or confirmed COVID-19 patients include standard contact and airborne precautions. Healthcare providers should perform hand hygiene before and after all patient contact with potentially infectious material, and before putting on and removing PPE. Wear clean, non-sterile gloves and a clean isolation gown upon entry into the patient room or care area. Respiratory protection that is at least as protective as a fit-tested, NIOSH-certified disposable N95 filtering face piece respirator is required before entry into the patient room or care area. Lastly, healthcare providers should wear eye protection such as goggles or a disposable face shield that covers the front and sides of the face upon entry to the patient room or care area. Patients should be instructed to practice good hand hygiene and wear a face mask when they are not in an airborne isolation room. There is currently no specific antiviral treatment for COVID-19. Prompt infection prevention and control and supportive management of complications is recommended. Patients with mild illness might not initially require hospitalization. Signs and symptoms might worsen in the second week of illness, according to the findings from China. The decision to monitor a patient in an inpatient or outpatient setting is made on a case-by-case basis. CDC has recommended that corticosteroids be avoided unless indicated for other reasons, and this is based on the potential for prolonging viral replication, as was observed in MERS-CoV patients. If a patient with confirmed or suspected COVID-19 needs to be transferred to another facility for care, place a face mask on the patient and have the patient transported either by a private car or, if they're unstable, by EMS. Immediately communicate with the next facility for transfer of information. Please don't send a patient without communicating in advance. Also communicate with the local health department if you have a suspected case. Local health departments in Virginia do not provide primary care, and none are providing testing for COVID-19 at this time. COVID-19 is a reportable condition in Virginia because it falls under the unusual occurrence of disease of public health concern in the Virginia regulations. Healthcare providers are legally required to report all suspected cases and confirmed cases to the local health department immediately. Lab directors are required to submit the initial specimen to DCLS within 7 days of identification. Healthcare providers are encouraged to report cases using our online and electronic reporting tool whenever possible. CDC has developed recommendations for assessing and monitoring healthcare personnel potentially exposed in a healthcare setting to patients with confirmed COVID-19. If COVID-19 is identified, healthcare personnel are assessed and classified a risk depending on exposure duration, patient symptoms, patient source control, and types of procedures performed, and the PPE worn by the healthcare personnel. Monitoring and work restrictions depend on the worker's exposure risk classification. For a confirmed case, BDH will coordinate with the facility to outline roles and responsibilities. And we've developed a risk assessment tool that's available on our website in the link below. There are specific actions that you can take now to prepare your outpatient setting. Post visual alerts at the entrance and in strategic places to provide patients and healthcare providers with instructions about hand hygiene, respiratory hygiene, and cough etiquette. Review the CDC infection control guidance recommendations with your staff. Ensure your staff are trained to screen patients for travel and respiratory symptoms. Review sick leave policies with your staff and make sure they're consistent with public health guidance. U.S. healthcare systems are reporting higher than normal use of N95 respirators and face masks. Some healthcare systems have begun reporting that orders for N95s and face masks are not being filled or are only partially being filled by distributors. CDC is encouraging healthcare systems to implement strategies now to conserve supplies. Strategies for optimizing supplies are located on the CDC website. If you are having shortages in your healthcare facility, you can reach out to your regional healthcare coalition. They may be able to leverage existing resources to support coalition members. And also try to explore alternatives to face-to-face triage and visits, for example, using telehealth to minimize healthcare worker encounters. It is important that patients are able to be seen in the outpatient setting for screening and initial diagnosis. If your practice does not have, you don't have fit tested staff or you're not able to test, please reach out to your local health department or work with your healthcare system to develop the systems and processes in place so that you're able to do this work. Products with EPA-approved emerging viral pathogens claims are expected to be effective against COVID-19 based on data for harder-to-kill viruses. Remember to follow the manufacturer's instructions for all cleaning and disinfection products, which include concentration, application method, and contact time. Additional steps will need to be taken if COVID-19 spreads in your community. Steps to consider include rescheduling non-urgent outpatient visits as necessary, reaching out to patients who may be at higher risk of COVID-19 related complications to ensure adherence to current medications and therapeutic regimens, to confirm they have sufficient medication refills, and to provide instructions to notify you by phone if they become ill. Accelerating the timing of high-priority screening and intervention needs for the short term in anticipation of the possible need to manage an influx of COVID-19 patients in the weeks to come is another step. Also, asking symptomatic patients who need to be seen in a clinical setting to call before they leave home so staff are ready to receive them using appropriate infection control practices and PPE is strongly recommended. Also consider eliminating patient penalties for cancellations and missed appointments related to respiratory illness. People who returned more than 14 days ago from areas where COVID-19 is active and do not have symptoms of COVID-19 do not put others at risk. To help counter stigma, healthcare professionals can maintain privacy and confidentiality of those seeking healthcare and those who may be part of any contact investigation. You can communicate the risk or lack of risk from associations with products, people, and places in a timely manner. We are all in a position to raise awareness without increasing fear by providing clear, accurate information and caring for our patients. Please continue to encourage your patients to take the steps that we recommend every day to stop the spread of respiratory illness. Educate your patients about how the virus spreads. Share the need for local social support for people who have returned from affected areas or who are worried about friends or relatives. And keep up to date with the epidemiology in Virginia and in your community to help provide accurate information and reduce fear. Noted on this slide are key CDC resources for healthcare facilities, including steps to take now to prepare for COVID-19. There's a lot of guidance on the CDC website, so these slides are specific links for you. There are also slides for resources for patients, both at the CDC site and the VDH website. So we encourage you to utilize those resources. Just a few slides about the public health response. It's a multi-layered response. The U.S. has been implementing public health measures that have slowed the spread of COVID-19 in the United States and have and are allowing us to better prepare in Virginia. A coordinated approach between healthcare, public health, and other partners as implicated will be implemented when cases are identified. We want to ensure appropriate infection prevention measures are implemented immediately. The public health response includes gathering necessary information about the case, contacts, and other factors as indicated. We need your help to identify cases, sometimes to conduct the public health investigation and to implement control measures. The current process to identify potentially exposed people based on the current epidemiology is through three mechanisms. First, airport screening. There's exit and entry screening occurring for flights from China and Iran, and there's exit screening occurring from Italy and South Korea. The second is monitoring and providing recommendations on restrictions and infection prevention measures for returning travelers and for contacts to cases. The third is conducting contact tracing on cases that are identified and implementing movement and monitoring restrictions. Until a vaccine and treatment are available, non-pharmaceutical interventions will be key to responding to local community spread of the COVID-19 virus. These community mitigation strategies are actions, apart from getting vaccinated and taking medicine, that people and communities can take to help slow the spread of the virus. They include personal actions, such as respiratory etiquette, hand washing, and staying home when sick. Also, community actions aimed at increasing social distancing in community settings, such as in schools, workplaces, and mass gatherings. And then environmental actions, which include surface cleaning measures, which are routine cleaning of frequently touched surfaces. We've learned a lot about COVID-19 in a very short time, but there's still a lot of information we need to learn. We don't completely understand the source of the infection. We're still learning about the pathogenesis and the virulence evolution of the virus and how it will behave outside of China. We're still learning about the transmission dynamics. What's the role of aerosol transmission in non-healthcare settings? What's the role of fecal-oral transmission? We're still trying to understand viral shedding and risk factors for infection. How risky are asymptomatic infections? And we still don't know whether there will be seasonality associated with this virus. So some take-home messages for you. Please prepare yourself, your staff, and your facility to safely screen and manage patients with respiratory illness. Review your practice emergency plans and stay updated with CDC and VDH guidance. Immediately report suspected or confirmed COVID-19 cases to your local health department. We have already seen cases in Virginia, and we expect the number to grow. We have to respond as a coordinated public health system that's public health, healthcare, and our community partners together. That's needed for us to successfully prevent spread in our communities and reduce the risk to all of us. Everyone has a role to play in preparing for COVID-19, and we're all in this together. So thank you for all you do to protect your patients in your community. This last slide has some information for links to our local health departments, to VDH, to CDC, and the World Health Organization. And finally, if you do have questions, you can email us at respiratory@vdh.virginia.gov. Thank you.
Thank you so much, Dr. Peake. We greatly appreciate your time. We have about 60 plus questions currently in the queue. And we know we only have you for a short time, so we're gonna just kick it right off. You gave a great deal of information, so I apologize if I'm repeating anything that was in your presentation, but given the serious nature of what we're dealing with, I figure it's probably worth reiterating a few points. The first question that comes to us regards setting up protocols for staff and volunteers, particularly volunteers who are retired or elderly. Is it wise for healthcare providers or healthcare facilities to send those people home? And then when it comes to preparing staff, obviously you mentioned a great deal in your presentation, but ideally what would those preparations look like?
So if you are using volunteers, make sure that they are trained and that they know and that they're fit tested so that they can safely assist. You may consider excluding high-risk volunteers, including those over 60 and those with underlying medical conditions or who are immunocompromised.
Perfect, thank you. Second question is, what particular risk are you aware of regarding the pediatric population and any unique things that need to be done from the provider perspective to deal with COVID-19 and pediatric patients?
So looking at the data from China, there really were very few cases among children. And among those cases, very few had severe or critical illness. But it is evolving, and so we're still learning about the situation. I think it's important to be prepared for children who are high risk, have underlying medical conditions, to be able to carefully monitor them and make sure that we are ready to care for them if they do become infected. We will probably be learning more from Washington State and from other countries, Italy, other countries that have much more spread than we do. So we hope to have more information about the pediatric population as time goes by.
Thank you so much. Our next question regards personal protective equipment, which I know you touched on in your presentation, but in particular, should folks be pursuing getting this equipment now, given what some folks have heard from the CDC and potential shortages might be facing, or should they wait until later and patients start presenting in their general area? What is the best practice there?
You should definitely be getting the PPE equipment now and getting your staff trained. We have cases in Virginia, and it may take time for PPE to come in, so I recommend that you definitely get the equipment now and get everybody trained.
Thank you. We also have a question here from a provider who had a patient return from San Francisco, and they are concerned, the patient is concerned they might have COVID-19. However, the providers is not allowed to use private labs for testing. What should this provider and patient do in order to get tested, if assuming they present with respiratory symptoms?
So I'm not sure why they wouldn't be able to use a private lab for testing. They may have said that they didn't meet the criteria for state testing, but if they are from a confirmed, if they're from an area in California where it is confirmed to have community transmission, then they should talk to their local health department. But also, LabCorp is providing testing now, so that is an option. And Quest is, but they may be restricting that more to the West Coast until they bring the lab online in Virginia. But you could try that.
Thank you so much. Next question regards pregnant patients in coronavirus. Are there any particular standards of care or special instructions we should be giving our physicians and our healthcare providers regarding that particular patient population?
So far, the data from China did show that pregnant women did not have worse outcomes than other adults. But we do know from SARS and MERS that pregnant women did have poor outcomes. So we still need to learn more about this population. There aren't any special precautions or instructions in place, but just like children, we don't know, we need more information to really understand this. So we should be prepared to carefully monitor them and treat them as potentially high risk at this time.
Thank you so much. We're getting a lot of questions regarding how to best communicate with patients. As providers, as you can imagine, physicians are getting a lot of phone calls, notably, should I stock up on water? Should I buy my own mask? What best practices and what resources might physicians be able to point their patients toward to help them prepare for COVID-19?
So CDC has recently provided guidance for those who are at higher risk of getting sick. And this includes, as we've talked about, older adults and people who have serious chronic medical conditions like heart disease, diabetes, and lung disease. So these individuals should take the following precautions. Stock up on supplies in case they do have to stay home. Take everyday precautions to keep space between away from others who are sick and limit close contact, washing your hands, avoiding crowds as much as possible, avoiding cruise and other non-essential travel. And then if there is a spread in our community, then to stay home as much as possible and to reduce their risk of coming into contact with others. It is not recommended that the general public use face masks, and we're really encouraging people to use their systems so that our healthcare workers and patients who have been confirmed to have the disease have access to those supplies.
Thank you so much. Next question is regarding diagnosing COVID-19. Notably, does it distinguish itself from the flu? Is COVID-19 or influenza or pneumonia and differentiate between those respiratory illnesses?
But this is a challenge when influenza is still widespread. So one thing we should be doing is encouraging everybody to get vaccinated against the flu so that we have fewer cases of the flu. It's going to be challenging because they are influenza-like symptoms, illness symptoms. So it is important to get that exposure history. So right now, when it isn't circulating in our community, you still have more opportunity to understand the epidemiologic risk of the patient. And then you can also do testing for influenza and other respiratory viruses if they don't have that epidemiologic risk, and even if they do. So it's important to rule out influenza and other respiratory illnesses.
Thank you so much. We just received a question, and it concerns that a lot of healthcare facilities and practices are already running out of masks, and masks are on back order. What should those practitioners do, and perhaps where can they go for the equipment necessary to deal with this ongoing epidemic?
So it's important for them to work with their regional healthcare coalitions. We are trying in Virginia, we have put in orders from the Strategic National Stockpile for PPE, and so hopefully we will be getting more orders in the future, and if we do, we will be working through the healthcare coalitions to help address shortages in the community as they're identified. So it is important now to reach out to your regional healthcare coalition and ask if they can assist. And go ahead, is there somebody has an update from the
So there is a website with contact information for your healthcare coalitions, and that is at VHAS, so VHASS.org/regional-info. And it would be important to reach out to your regional healthcare coalition to let them know about shortages so that they're aware. They may also be able to provide contact information for other vendors who may still have supplies.
And another strategy is also to really look at all of the new telehealth options. There's a lot of, there's been so much change in this field since we were preparing for a pandemic flu that it does create more opportunities. And in Washington and San Francisco, in California, where they are having community transmission, they're looking at strategies like having specific times at the end of the day where they're just providing testing or workup for patients who are concerned that they have COVID-19, and then looking at ways to really limit the amount of time that you would need to be interacting with those patients.
Thank you so much, and we'll be sure to put those resources on MSV.org's website. The next question is regarding, it seems the CDC is advising specifically elderly patients to avoid travel in crowds. Is that generally what we should be communicating to our patients? And what specifically advice should we give them regarding leaving the home, travel, crowds, and those kind of things?
So I think that as far as travel, you can follow the CDC website for the travel alerts, and there is now information from the U.S. State Department that recommends avoiding cruises. And then particularly to Asia, there's also a specific recommendation to not take cruises to Asia. So I would recommend that you communicate to your patients to look at the travel sites, look at the State Department and CDC recommendations about travel. So I do think that we also have to talk to our patients in a way that isn't creating unnecessary fear. This will go on for a while, so just like seasonal flu, this isn't something that just lasts a short time. And so we have to be realistic. And at this point, we do not have signs or evidence of the virus spreading in a community in Virginia. So when that does occur, the response will be very local, will be driven by the local epidemiology and situation. So this is a time to stay connected to what's happening in the community, to be getting updates from your local health department and from BDH so that you can provide guidance but not overly scare your patients.
Thank you so much. Given that we only have one more minute, I'll ask a final question, probably something that I know you covered in your presentation, but worth repeating, is if a physician has a patient present with respiratory symptoms, potentially they need to be screened or tested for COVID-19, what should that provider do next? Specifically, what are the steps you would like these folks to go through to get that patient taken care of?
So place the patient in an isolation room or an exam room that has the door closed, put a mask on the patient, and then also just to make sure that you are screening for travel history, work up the patient for other respiratory pathogens and make sure that they don't have influenza or other pathogens. And then if you are going to transfer the patient, make sure that you make those arrangements ahead of time. You don't just ask the patient to leave. Thanks.
Thank you so much, Doctor. We know we're at the end of your time, and we want to thank you once again. To repeat, this entire webinar will be on msv.org/COVID-19 shortly. Also, we had a lot of questions we did not get to, but please email them to respiratory@vdh.virginia.gov. And I know the good folks at VDH will try to respond to everyone as quickly as possible. We want to thank Dr. Peake once again. We want to thank the great staff at VDH, who I'm sure haven't been sleeping several days now to get this addressed. And we will put this online shortly. And should you have any questions, please contact VDH or MSV, and we will happily give you the right information. So thank you to everyone once again for attending, and we greatly appreciate it. Take care.